Hey everyone, welcome back to the Long Haul. Today I'm joined by Dr. Michael Abraham, who is at the University of Kansas as an associate professor of neurology and radiology. He is also the stroke research director. A little bit about his training. He completed his MD at the University of Missouri in Kansas City, residency in neurology at the University of Kansas Medical Center, as well as a fellowship in interventional neurology and neurocritical care at the Medical College of Wisconsin. First off, Dr. Abraham, thank you for joining us and telling us a little bit more about what you do and your specialty.
Yeah, thank you for the invitation. Great project that you're doing. So I did a 4-year neurology residency after med school, and that comprised of covering the neurology as a whole, so all of its subspecialties, including stroke, neuromuscular diseases, multiple sclerosis, epilepsy and seizures, movement disorders, neuro-oncology, neurocritical care. After those 4 years, I went on to do 2 fellowships. It was an integrated fellowship in both neurocritical care and interventional neurology. So a little bit about what those specialties entail. And as a neurocritical care physician or a neurointensivist, basically it is an ICU for people with a primary severe neurological disorder. So people with different kinds of brain hemorrhages, people with stroke, so a blocked artery in their brain, people with brain tumors or other types of disorders that cause severe swelling in the brain, people with severe seizures that are having continuous seizures, what we call status epilepticus. So those are the main things that we see in the neurocritical care unit. And then for the neurointerventional side of things, the other names for interventional neurology are interventional neuroradiology, neurointerventional surgery, interventional neurology, because there are basically 3 types of physicians that can go into that. So you can come from a neurology background, a neurosurgery background, or a radiology background. So there are 5 of us at KU that do neurointerventional surgery. 2 of my partners are radiology background, 2 are neurosurgery, and then myself, neurology background. But essentially, we all do the same thing. And what that entails, basically everything we do is through a small incision at the top of the leg, going through either the common femoral vein or the common femoral artery. These are large veins and arteries there. And we first get access into that vessel using a small needle, and then we run these tiny wires and tubes called catheters, basically around the aorta and into the various arteries going into the brain. And through these catheters, we can inject contrast dye, and there's an X-ray machine basically above the patient and to the side of the patient, so we can get real-time continuous X-ray guidance as we move our devices, just using our fingertips and angling them into the brain. So doing that, we can do what we call diagnostic angiograms, where we simply are taking pictures to better understand the vascular anatomy of the brain as well as in the neck. And that can help us, decide if somebody needs further treatment. Additional things we can do is something called clot retrieval or endovascular thrombectomy. Through these same catheters, we can literally get into the clot and either suck it out with what we call an aspiration catheter, or there's another device called a stent retriever, which is essentially a retrievable stent. You can deploy this stent in the artery, it opens up into the clot, and we can pull it out. Other things we can do, we can also treat brain aneurysms as well. So if this is your artery, an aneurysm is just like a balloon or a sac arising from there. So basically what we can do, again, through a small incision, is we can get a small microcatheter, which is about 2 millimeters, into the aneurysm, and we can fill it with these types of platinum coils. And these coils, we just fill it up until no more blood goes in there. So that diverts the blood flow away from the aneurysm. We can also put stents in the arteries and veins in the head and in the neck as well. And then additionally, there are people that have these different types of vascular malformations, which are essentially an abnormal connection between an artery and a vein, and those can also rupture or bleed in the brain. And basically the treatment is to somehow cut off that abnormal connection between the artery and the vein. And one of the ways we can do that is, again, taking a small microcatheter, deep into this vascular malformation and injecting a type of medical glue that cuts off that connection. So that's kind of a brief summary of what I do.
I see. Very cool.
Yeah.
Why did you choose to specialize originally in neurology? What drew you to that specialty?
Yeah, so it was actually early on in high school. We were supposed to do a project in our anatomy class. And at that point, I was really fascinated with the nervous system. Just because, when you cut open a brain, there are no moving parts, but everything, starts from the brain, essentially, emotion, speech, movement, coordination, all these things happen so well and so precisely coordinated. So it just really fascinated me. And so throughout high school, I knew I wanted to go into medicine, and I knew I also wanted to do something, in the neurological side of things.
Gotcha. So going into medical school, you already had that kind of notion that you wanted something neurology or brain related.
Correct.
Okay.
Yeah.
If you could tell us, what is the most rewarding part of your job?
I would say stroke treatment. So, prior to the advent of these devices for us to get in, pull clots out, patients could have very debilitating outcomes where, they could not speak, can't walk, just can't interact with family, friends, those things that, it's easy to take for granted. But with the advent of these devices, the ability for us to get into the brain, pull these clots out, goes much more quickly and is much more successful than prior treatment. So being able to see somebody who comes in, not moving one side of their body, not able to speak, and then after we pull the clot out, maybe within a few hours they may start to speak, they may be able to start moving that side of the arm or the body that was paralyzed. That is probably the most rewarding.
Right, definitely. With that same
Yeah.
token, what is the most challenging part of your job?
Sometimes deciding to do too much. So I'll explain what that means. There's a phrase we use a lot in our field called the enemy of good is better. So sometimes with, let's say for an example, a stroke, somebody comes in with what we call a large vessel occlusion, a main artery that's blocked. We can go and pull that out. Our devices are well designed for that. And when you pull that out, sometimes a piece of that clot may break off into a smaller distal branch. We have tools to go after it, but there's also that risk of making things worse. So sometimes if you're trying to go for a perfect picture, you can also hurt the patient as well. So sometimes it's a balance of deciding, what's the best thing for the patient in those situations.
I see.
Because because with that you can get complications, including worsening the stroke or even hemorrhage as well. Because we're dealing with arteries that are ranging from 1 to 4 or 5 millimeters, so very small.
You mentioned that a few of the doctors at your hospital, you guys do these certain procedures. Do you guys work on cases together, or is it you have your individual patients, or it depends?
Yeah, for the most part, individual patients, but there's a lot of collaboration. We have every other week we have a neurovascular conference where we have challenging cases. We'll get the input from everybody on it. So it's a good working team where we have a lot of interaction and bounce ideas off of each other. And sometimes, yes, we will scrub in together as well, especially if it's a very long case or something.
Mm-hmm. A little bit about the lifestyle. If you could take us through maybe the hours and if you have call on the weekends and that sort of thing.
Yeah, so typically around 8 o'clock in the morning, we have a team of residents, med students, pharmacists as well, and the nurses. Rounds last anywhere from 2 to 3 hours. Then typically work on notes. If there's like bedside procedures that need to be done, we'll do those. Typically give a lecture to the team in the afternoon, and then we do like a brief end of the day rounding to go over anything that we were supposed to do throughout the day. And then call for that, basically if people are coming into the ER or directly as a stroke, we'll admit them, but there's somebody from our team in-house. So I don't have to be here at night. That's the neuro-ICU side of things. And the interventional neurology side of things, again, when I take call, it's a 7 to 7, or sorry, Monday to Monday, call. So anything that comes in day or night, the things that would come in in the middle of the night are like an acute stroke where they need, clot retrieval. And then there's some people also who have severe nosebleeds that can't be treated by, packing the nose, and will actually go into the arteries supplying the nose and block those off with coils. So that's kind of that schedule. Like I said, anything can come in 24/7. And then outside of my call weeks, I have scheduled cases. Like today, I have, 2 scheduled cases, and then, just research meetings and things in between.
I see.
So overall, I take about 19 weeks, I think, of call a year.
19 weeks. Okay, gotcha.
Yeah.
How competitive is it to match into a specialty like neurology?
Neurology, it is becoming more competitive, especially as there are more advancements in the not just the stroke world, but other subspecialties in neurology. I think it is becoming more competitive.
Gotcha. If you had the option to go back in time and change your specialty, would you?
No, I love what I do.
Gotcha. And a common misconception about your specialty?
When people hear interventional neurologist, a lot of people have no idea what that means. So, like I said earlier, because there's 3 backgrounds I can go into this. So that's why I always try to describe. I say interventional neurology, and then I describe, follow that up with a description of what I actually do.
Right. Typical compensation for a neurologist?
For general neurologist, meaning, you finish your residency and you just go out into practice, you can make up to 400,000, I think, like, especially in like smaller practices, like smaller cities and things like that. Like, you grew up in Columbia, Missouri, so like somewhere like that, or Springfield, Missouri, where I grew up, as a general neurologist, you can do well.
Gotcha. Last question for you today, Doc, is what advice do you have for people studying to become a physician?
Make sure you enjoy it. Make sure it's what you want to do. I know there's some people out there who may be pressured to go into med school and things, so make sure you enjoy it. That's one. And also, like, as you're studying, try to really understand what it is, you're studying. And I think the way med school has gone, when I took it, it was different than current day. And current day, I think it's much better in that they do like an organ-based, like a systems-based, where you don't just learn one part, like the normal stuff and the diseases. Is kind of incorporating everything, which is nice, which gives you a better understanding of it. And then when you are a med student or a resident, you will get everything that you put into it. So, on rounds, be active in rounds, even if it's not your patient. There's so much to learn. Go in the room when the team goes in the room, even though it's not your patient. So essentially, just get your feet and hands dirty. Essentially, be very active, and I think it'll be a much more fulfilling experience.
Gotcha. Dr. Abraham, thank you again for coming on and telling us a lot more about your specialty. We definitely learned a lot. We appreciate it.
Yeah, sounds good. Thanks so much. Have a good one.